Hello? Hello? Hello, I would like to welcome everyone back. I hope you all enjoyed a heart-healthy lunch in the CMS cafeteria. And I don't think anyone took a walk today. Yeah, so we will resume. And on the schedule is discussion among the MEDCAC panel. But most of the presenters have kindly agreed to stay because I think a few of the members have indicated they might have questions. So we will do that for a sort of brief period of time because we are at a hard stop. And we obviously have to get to our discussion and questions. And I also understand that you wanted to make some comments, so please do take some time now. And
all right, thank you. I'm Vicki Beckler, and I wanted to address Dr. Mock's question earlier or comment regarding Georgia having so many lung cancer screening centers of excellence that follow the Lung Cancer Alliance framework. And basically, the state of Georgia, as part of their comprehensive cancer control plan that was recently rewritten as part of the CDC's national efforts to rewrite the state's plans, took it on as a developmental goal, lung cancer screening, in collaboration with a lot of other organizations throughout the state. So I'm happy to report the state has actually exceeded what our developmental goal was set for Georgia. So
was that with the backbone of a CON?
Pardon me?
Was that with a certificate of need model? Or?
No. It was just part of the developmental goals that were incorporated in the state's plan, the Comprehensive Cancer Control Plan state's revision to take on lung cancer screening.
Thank you for
You're
that
welcome.
clarification.
Thank you. Dr. White, I think, did not get a chance to ask any questions before lunch. So.
I had a question for Dr. Kazerouni and Dr. McNitt-Gray, and it has to do with the, we established the existence, I think, of standards. I want to ask about the ACR accreditation process for low-dose CT screening. Two questions. One, are the standards for the accreditation process on both the clinical and the physics side comparable to what was proposed or what was done on the NLST, or either higher or lower or different in some way? Then I have a second question after.
Okay. I'm happy to report that Dr. McGray is the physicist on the CT accreditation program and helped us develop the ACR lung cancer screening CT standard and technical parameters. So we can both speak to that question. The ACR is one of 3 designated organizations under MIPA to accredit ambulatory care facilities for purposes of Medicare coverage and reimbursement. So currently the ACR accredits the majority of outpatient CT scanners in the United States. Under the CT accreditation program, we have developed a specific center of excellence or programs, designated lung cancer screening programs, which have lower radiation exposure CT scans, which meet, if not exceed, the radiation exposure, if not exceed in the lower direction, the lower limits of radiation exposure that were set by NLST. So we expect through our accreditation program that radiation exposures will be lower than what was seen in NLST.
And so my question was not just about the radiation exposures, but about things like criteria for entry into the screening program, things like that?
Yes. So as well, we have standards about the physicians and their and who interprets lung cancer screening CTs. We have standards about entry criteria into eligibility for lung cancer screening, and we also mandate lung cancer smoking cessation as part of lung cancer screening programs.
Then the second part of my question is, if a facility wishes to be ACR accredited for CT and they do low-dose CT lung screening, do you require that they have your credential in low-dose CT screening in order to be accredited by the ACR, or can they be accredited by the ACR and CT, do the low-dose screening, but not meet your low-dose standards?
So in order to get the designation of being a lung cancer screening designated center, they have to meet our criteria. These are subject both to attestation as well as to practice audits. They cannot receive the designation from the ACR unless they're part of the ACR CT accreditation program.
So my question is not about the designation. It's a MIPA-related question. If someone wishes to use the ACR accreditation to qualify for MIPA payment from CMS, and they wish to do low-dose CT screening, do they need to meet your low dose requirements, or do you pull the accreditation entirely if they don't meet the low dose requirements and claim to do low dose CT?
So the CT accreditation program is a broad one. It does not just cover lung cancer screening CT. It covers neuro CT, musculoskeletal CT, cardiac CT. So the global designation for CT accreditation depends on the type of exams that you perform at your center. Sites can specify the types of exams they perform. For example, some sites don't perform pediatric CT, and they would not submit that for accreditation. So if they want to pursue lung cancer screening CT designation, they have to submit and conform to the requirements of lung cancer screening designation.
And I hate to belabor this because I think this is an important point. And if under your program, if someone wishes to do, say, neuro CT, they can't just say, we're going to skip the neuro part, but we're going to get accredited for abdomen, and then continue to do neuro. You don't allow them to do that.
Right, if they
do you allow them to do the low-dose CT screening if they're otherwise accredited but don't meet your low-dose requirements?
So I think we're kind of saying the same thing, but just using different language. If you want to have designation for accreditation under the ACR's lung cancer screening program as a designated center for lung cancer screening, you'd be required to follow the requirements for low-dose CT, smoking cessation, and the appropriate population being screened. If you did not meet those requirements, you could not have ACR designation as a center for lung cancer screening.
But you could still bill CMS for the low-dose procedures. I'm trying
As a global question under MEPA, that's probably already existed. We're trying to improve that by having a specific lung cancer screening designation.
Okay, I'm going to follow up question to that, and then Dr. Burke and Dr. Rich have questions.
Sure.
So my question is sort of, again, from the patient point of view. It's not clear if a patient knows if they're going to an accredited place or not. And then beyond that, as I read from the public comments and from the published literature, even if you have a low-dose protocol, it doesn't mean what a patient gets is actually a low-dose CT. And we know, for example, Rebecca Smith-Byman published a study in the Archives of Internal Medicine in 2009 showing even at the same institution there was 30, 40, 50-fold variability in the amount of radiation. I know there were hearings held after that study was published, and there was talk of changes. Have there been any changes since then that have minimized that variability?
Well, part of practice audit under the ACR CT accreditation program is radiation exposure as a quality parameter. So that is an important quality component of an accreditation program.
And do patients know how much radiation they're getting from a CT screening?
The amount of radiation exposure and how it's implemented varies widely across the U.S. in terms of how information is communicated to patients. As you're probably aware, in some states like California, there's requirements for documentation in the radiology report. What information that is and whether it's the right or the best way to commute radiation exposure and risk, I don't think people yet understand the answer to that question. Radiation risk is a relative one, and to simply report a number without a risk assessment of what that means, whether it's a 2-year-old, a 15-year-old, or a 65-year-old, is very important. To just simply convey a number to a patient without explanation, I think would be inappropriate.
Okay. I'm good. Dr. Burke?
Thank you. So this is a question for Dr. Pinsky. Dr. Pinsky. So Dr. Pinsky was kind enough to allow me to look at the paper that he referred to earlier about the results stratified by demographics, including gender. And in Table 2, there's a relative risk of disease-specific mortality of 0.87 and a relative risk of death of 0.92. And these were covariate analyses for the p-values, but the 0.87 was for the over 65, and the 0.82 was for the under 65. So there was a stratification by under 65 and over 65 in terms of the benefit. And just from my conversations informally, I was told that this 0.87 wasn't a significant value. Is that correct?
I mean, it probably would not be, just because that's a small subgroup and the trial was powered, to find a significant effect of screening for the whole population. So once you do stratified analysis, it's unlikely that any given strata is going to be significant.
Right.
And the other point, the 0.87 versus 0.82, there's going to be some chance variation, and there was no hint of a statistically significant interaction, meaning a statistically significant differential effect by age, even though, they were nominally different by 0.87 to 0.82.
So would it be reasonable for me to conclude that the NLST did not find any significant effect for patients over 65?
I think that'd be a misleading way of characterizing it.
Well, I'm looking at the number, and it's not significant.
Well, the way I would characterize it is, overall, we found a significant effect, and we did not find any evidence that it was differential by age. So by that, I would conclude that there's evidence that it's effective for all the age groups in NLST.
All right, but just to hone in on, so the 0.87 wasn't significant.
Well, I don't
Is that
recall,
correct?
because the over age 65 was only 25%.
Right,
That's
I
a very
understand the temporizing
small group.
characteristics, small group and everything
I would-
else, but I'm just looking
it
for
probably
evidence.
was not significant.
Okay, so the
Right.
evidence isn't there for over
I
65.
wouldn't characterize it that way.
Okay, thank you.
Doctor, did you have a follow-up to
Well,
that?
I have
Because if not,
just kind
Dr.
of an extension of that, if you will, please, Curtis Mock. The 25% that's Medicare age that wasn't supported by that data, if we have 96% of that study that's false positives, and 25% doesn't represent the Medicare data, my question is really to any of you presenters. Tell me where your discussions are around formulating a more accurate stratification system or an identification system to narrow those members that are going to get subsequent follow-up and secondary studies. It seems as though there are a lot of clinicians here and the presenters today. I'm really anxious to know, in your discussions around this topic, where are you going with the comorbidity of the smoker who is age 66 through 80, now getting a false positive result and subsequent workup? In my experience as a practicing clinician, the patient that's 45 that smokes has significant risks. The patient that's 67 to 76 has additional risks that are quite material. So where in the stratification and the identification of that narrow band that's going to benefit from screening is your discussion?
So there have been numerous discussions at the professional society levels about trying to come up with registry systems to capture exactly this data. In the STS database, and Doug's probably in a better position to speak about it because he's a former president of the STS, we have 10 to 15 years of experience of getting data from the surgeons going down to specific surgical issues, and it's very easy to build upon that, the sort of surgical components that came to the people who came to surgery through the screening program. What we're trying to do that is to use that as a template to go further upstream and try to adjust databases like that was used in the ILCAP study as well, to try to prospectively collect that data, because we really view a revision of the recommendations about every 7 years, that they'll be revisited and tailored down. There's a lot of new technology that's going to come online in the next 7 years that will probably supersede trying to come up with 30 pack years and ages 55 to 80 that will make it a more pure population of risk that you're going to apply screening to.
So that net seems to be wide for the next 7 years, and that's really where I'm looking to close.
Okay. Please come make your remarks brief.
This is Doug Wood. I think it's a thoughtful question, and as noted in many of these presentations, there's an effort by us and our professional organizations to work on creating algorithmic approaches to management that can help decrease variability in how these workups take place, to minimize the unintended consequences of further workup, the NCCN being one of those. And that's updated annually. So one of the things I showed is that, for example, we changed the definition of a positive scan from 4 millimeters to 6 millimeters, given new data from the ILCAP. with the goal that makes it yet a step better. And so we're not perfect. We're far from perfect. But I think we do have aspects of algorithmic approach that can make it as capable as possible.
Thank you. And then we really do think that these changes we make, even though we haven't done studies to prove it, of course, we think that's going to help.
I'll be very brief.
We think it's going
Exactly for this topic, 10 seconds.
Exactly for this 10 seconds. Lung RADS is a structured reporting and management scheme that builds on the data that was from LCAP and NLST and other studies to make sure we manage patients appropriately. Only 1 in 10 people getting lung cancer screening using lung RADS will be defined as a positive screen. Most of this is because nodule classification sizes have gone up because we know that what we can follow.
Thank you.
And we know that based on data that's been collected. So it's only 1 in 10 will have a positive screen. So to
Okay,
say
thank you. We're gonna move on now.
positive is inappropriate.
Bruce Pynson, narrowly on the topic of how wide the net is, the net of at-risk people in the Medicare population is actually rather narrow based on the NLST criteria. And if you compare that to the screening of mammograms or colorectal cancer screening or cervical cancer screening, it's a rather narrow population that generates the vast majority of cancers. So compared to everything else that Medicare is funding, you already have a much narrower net.
Thank you.
Of course, it can get much better.
Yeah,
Thank you.
my concern was the variability in follow-up. That really was the point of my question. How many are we catching, and then how many are following up? And is
Yeah.
it 3 months? Is it 6 months? Is it 3 to 6 months? We look for standardization.
You know,
If I
we
could
have a
just
limited amount of time left, and I just want to, if you want to repeat things that have already been said in your presentations, we really did listen to your presentations and read the slides. So if you have new information, but you have
I
some
think
new
the rest of what
information.
Ella might have said was that not only are the new thresholds going to reduce the number of false positives, it's a misconception to believe that all those false positives go to biopsy and pathology and so on. Most of them are weeded out with just a little more look, like a follow-up CT. So when we talk about false positives, we shouldn't think of them all as undergoing risky procedures and expensive downstream procedures. Thank you.
Thank you. Next is Dr. Rich, then Dr. Grant, then Dr. Hyatt.
Sure, this will be quick. It's for LCA or for anybody else who wants to take it on. So looking at the trial, it's 3 annual scans, and then it's been extrapolated to say get an annual scan. Let's pretend that we decide or CMS decides that they can't go to an annual scan. What would the minimum amount of scanning that you would see acceptable, clinically acceptable for these patients? Do they get 3 annual scans and then just get forgotten, or do you repeat that cycle after a 3-year rest period? Any ideas?
The risk of lung cancer after tobacco exposure is continuous. So biologically, it would make no sense to do 3 and stop with the data we have at hand right now.
Thank you.
And as you heard from Dr. Pinsky, there was no intention from the developers of the NLST to do that.
If you wait for 3 years, you're back to the baseline round as though you've never been screened. The annual is the same. What you find on annual is the same year after year after year. As age increases, you find more cancers, but not less.
The last point that I would make, which has not been made before, is USPSTF did model that, and they looked at annual scans, triennial scans, and biannual scans, and their data is available as well.
Right. This is for Dr. Wood. Can you describe to us the surgical mortality? There's some question raised at lunch that can you really do a lobectomy in an 80-year-old at 1% mortality, or is there a linear creep in mortality as patients age?
And to add to that, also please talk about the video-assisted thoracic surgery and how much it improved the outcomes after lung resection.
Certainly. Doug Wood, so to the first question, 80 is the old 60. We actually take care of 80-year-olds all of the time now in surgical patient populations. And it turns out that because we're good at patient selection, the mortality is not meaningfully different than in younger patient populations. And it's because of selection bias. We certainly, as surgeons, are good at selecting the best 80-year-olds. But that's what we're supposed to do. That's what we're supposed to do. The mortality rate for 80-year-olds is in the 1 to 2% range in multiple studies, just as it is in the under 80-year-olds. In terms of VATS surgery, minimally invasive surgery is now widely utilized for both diagnostic and therapeutic purposes. Some of these nodules ultimately have a diagnostic wedge resection done by VATS, which is minimally invasive, with most patients discharged the day after surgery. But VATS is also used therapeutically for the lobectomy procedures, again with shorter hospitalizations and decreased complications.
And mortality too, or only hospitalizations?
Actually, not a significant difference in mortality, but a significant difference in complications and hospitalizations.
Thank you.
Speak to that. In the SEER Medicare data, which is a reference standard, the 30-day mortality is about 4.5% for people 79 to 80. The nationwide inpatient sample, which does not have staging information or good detail on surgical information, but even with the surgical codes, the mortality is about 4% in the 75 to 80-year-olds.
Thank you.
I just have a quick comment. As a surgeon, there's other modalities out there like SBRT that you can use in 80-year-olds that aren't good surgical candidates that have excellent results for the treatment of lung cancer. And those are developing every day.
Thank you.
Thank you. Dr. Grant.
Just very briefly, Dr. Pinsky, correct me if I'm wrong. I just want to go back to this exchange about effect modification by age, that in fact there was none in the NLST, and this analysis, it's relatively, well, it's not crude, but it's dichotomized, so you really can't look at the continuum. So just to make that clear. The relative
Based on the
effect
stratification of under and over 65, there was no evidence of effect modification or interaction or differential effect by age.
Okay.
Dr. Hyatt.
So for Dr. Cazzaroni, I know and this may be unique to a prepaid environment without significant cost share, but if our clinicians aren't extremely specific in how they order the chest CT, the patient does not get the low-dose protocol. And perhaps in the world where the patients have significant cost share and they know that that's supposed to be free, that maybe it would be different. But I'm concerned that a significant portion of these studies may end up not being low dose. They may be performed as a regular chest CT, which is more exposure and potential risk, and especially as patients move site to site, they may not know that the patient is getting annual low-dose CTs. So how would you protect the patients from that?
So I would say there's no difference in chest CT for screening and diagnosis than the analogy for breast cancer. In breast cancer, we have screening mammography, which is a certain number of views, and we have diagnostic mammography, which is tailored for patients who have symptoms or have palpable abnormalities. Chest CT is no different. If you order a screening chest CT for lung cancer, that by definition is a low-dose protocol. But if you order a chest CT and you say hemoptysis, that's now a diagnostic clinical piece of information that's outside the screening setting. So it's incumbent upon us to make sure that we're getting the appropriate intake so that we can then perform the right exam.
So would you require that for anything that doesn't say screening, that they must indicate the reason for the study, because that's not all that easy to impose?
Currently, in order to be reimbursed by almost every third-party payer, you have to have a clinical indication for an examination. So I'm not certain as to what the question is.
Okay, so that you just answered it, because since we don't send bills to anybody, then
yes, in order to get reimbursed for CT services, we are required to provide information about what the clinical indication is.
Okay,
and we're also required to make sure that they're appropriate.
Okay, Dr. Gould.
Yeah, a question for Dr. Bach. We've heard several speakers today talk about the advisability of starting registries to monitor the outcomes and the safety of screening in other settings. And I know you've written about this and are an advocate of registries. Can you give us an idea of where they should sit, who should be responsible for them? There are a lot of moving parts, as you say, and it's encouraging that the thoracic surgeons have a registry, but that's 2% or less of the patients who undergo screening. So do these run out of radiology departments? Do they run out of some centralized statewide agency? What are the options? What are the pros and cons?
Thanks. It's Peter Bach. Thanks for the question. There's not a single answer to this. In Medicare's history under CED, there's been a number of different platforms for gathering data and registries. They've sat in a variety of different places, including in professional societies. For example, for the implantable cardiac defibrillator registry, they've sat separately at universities, like it was done at the PET registry, which was done in collaboration with a couple of professional societies as well. I think it's unlikely this needs to sit within the agency, and think that that's unattractive. And one of the themes I think we're hearing here today, if I can reinterpret it, is that there's actually quite a bit of interest in doing continuous quality improvement, and registries form the backbone at least of that. There's an issue that, although they are indirect evidence of efficacy or harm, just the simple counting of false positives, procedures that are done, what those procedures show, and how often lung cancers are detected are all basic elements, I think. Under CED, the regulations state that you could actually use the registry to provide additional coverage criterion. Much of what's being discussed today are things like smoking status, not just smoking yes, no, which is what the standard and meaningful use is for EHRs, but 30-pack years or 50-pack years or whatever. In order to capture that information for coverage or additional determination of coverage, CED in a registry could be used. So I think those are all good things that are moving that direction. I think there's a lot of work on the ACR side. I already pointed this out around algorithmically defining follow-up. Some of the stuff we saw from Leahy showed that very nicely. It was a lot of boxes. It looked complicated, but it seems like something that could be codified. And I think those are all sort of things in the right direction. I've asked for recognition of centers. I take Chris Berg's earlier point that the right dichotomy is centers that have adequate expertise and breadth to do this, not a place that just has residents and so therefore is an academic medical center. I think that's important. And I take Doug's point as well. The surgical mortality rates nationally are much higher than they are in places with expertise like the University of Washington where Doug practices. And that's an important thing to think about, particularly when we're intervening on patients who are otherwise healthy and we're leading them down a medical road.
Thank you.
Jim Mulshine. At Rush, we're a member of a PCORI-supported CDRN that is capturing data on outcomes for a variety of things, and they have a funded mandate to look at outcomes in preventive services. And they're very interested in doing this, and in fact, we're entertaining Dr. Selby in the next couple of weeks to talk about the possibilities of integrating the concerns that appropriately have been expressed here with a national infrastructure that's already being developed to do exactly these types of things.
Dr. Redberg, there still is, it's Curtis Mock, there still seems to be some confusion. I wonder if we can clarify it before we move on. Even though there's an interest to move forward to identify those that are screened, there still is some misunderstanding about whether the follow-up radiation exposure is the same as that of the low dose or whether it's higher.
Right.
And not being certain about how many scans the patient gets in follow-up before they drop back into the screening. I'm getting two different answers, and I want to clarify that.
Well, I think certainly when you read NLST, there was no protocol and they were all over the place, and a lot of the follow-ups were full chest CTs that were reported at much higher doses, 8 millisieverts, and I am certain that in actual practice it would be even more variable and at higher doses because you
Okay,
don't see
thank you.
clinical
That's good enough for
trials
me.
in
Thank you.
actual
Address
practice.
your question directly. Because of the reduction in false positive with lung rads, fewer people require interim CTs. For the people who do require a downstream
Dr.
diagnostic
Kazaruni, you haven't
test,
actually shown us any data from lung rads, so that's why I prefer to keep discussing the evidence. We look forward to seeing data from lung rads, but right
uses
now
the
we
evidence
haven't.
that is already available in the LCAP and
Can
NLST
you give us
databases.
those references?
I think you have much of that in USPSTF references already, from which we've extrapolated the data and developed lung rads.
Okay.
It means that
We
the
ha-
follow-up
I haven't
CTs
seen
will
it.
all be low-dose CTs, except for the 2% that are at the very highest risk for cancer who may undergo more aggressive diagnostic pathways. And that is a very important point. Most people with a positive CT who need a follow-up test will get a low-dose CT.
So my understanding is you'll get the same
protocol
CT
has-
that you got that showed the nodule in the first place, but you will just wait over time. And while you're waiting over time, of course, it's unclear whether or not you have cancer or not. You're waiting over time to find out, and there's a lot of uncertainty and anxiety associated with that. Did you have a new point, Dr. Henschke? Because otherwise I'd like to thank the presenters.
Well, I just wanted to say that our protocol has always specifically asked for a low-dose follow-up CT. One, if there's no growth, then you go to the next annual screening. And that has not created a lot of anxiety in all the patients that we've done. You have to talk to the patients. You have to talk to the participants.
I would love to see the quality of life data from the NLST. So I want to thank all of the presenters. We appreciate your time. We did all read your presentations and listen carefully. And we now have a little bit of time left for discussion among the panel. So I will open it for discussion among the panel. And if anyone, and I in particular, as you can tell, am interested in discussing a little bit more of the harms of screening, and because I don't feel that I understand fully, from the NLST, as we talked about the quality of life. I'm looking now at a paper called The Harms of Screening, a proposed taxonomy and application to lung cancer screening from Russ Harris, published in JAMA Internal Medicine, who was a former member of U.S. Preventive Services Task Force. But among other things, he notes that twice as many NLST participants in the screening arm experienced a serious complication from the workup as had their lives extended by screening. And then there's also discussion of the psychological harms and the waiting and the follow-up procedures, all of which I think were fairly low in the NLST. But again, I think in actual practice, we know that things are not like in clinical trials, and that people seem to get more testing and less careful inclusion in screening studies. And so I'm concerned that we haven't really explored the harms, and in particular in the Medicare population. We're basing now the age 75 to 80 on a model which Dr. Bach told us was very inconsistent. I personally couldn't understand the data that the model was based on from reading the task force statement, which I did carefully. But I do know that surgical mortality does increase as one gets older, and that in general the benefits of early detection tend to disappear as you get older because there are more competing causes of death. And so I am concerned that we don't really have a lot of data in the Medicare population, certainly not in the 75 to 80, and particularly on the harms in the group the age group that was included in NLST.
I have another concern about the financial comments that were made. It seems as though there might be some lack of detail around the specificity that came to the dollar per year of life saved. I'm not clear on that. I did hear the figure, but I didn't hear the standardization upon which that calculation was based. Maybe someone else on the panel can help me understand that better.
I don't know. We're really, I think, concentrating on clinical effectiveness today, and not, while Medicare is allowed to consider costs for preventive services, I don't think that.
I didn't want
really
that figure to get
today.
out after today's discussion without comment.
I see.
So can I just point out that my understanding is that there is an NLST cost effectiveness analysis, but it has not yet been published. So we don't have that information at our disposal.
Thank you.
Dr. Wolf.
Yeah, I wanted to build off of your comment and begin by saying that my understanding is that the starting point for this entire NCD is the task force recommendation. I mentioned at the introduction that I spent 16 years with the task force, and I have to say that in my day, looking at the evidence that's been presented, this would not have received a B recommendation. It probably would have gotten an I recommendation, maybe a C. And the task force concluded that the B recommendation was appropriate because it reached the conclusion that the net benefit, that's the benefit minus harms, was substantial. Now, we can talk, I'm sure we will, about the validity of extrapolation to older age groups and so forth, but even if we just stick to the data, the only evidence that the task force relied on in making this recommendation was one trial. Granted, it was a very good trial, but it was one trial and a modeling study. And just in terms of context, the other major cancer screening tests that we've implemented in the United States and in other countries have been the subject of multiple randomized controlled trials. Mammography, colorectal cancer screening and others, we have never relied on a single randomized controlled trial to set national policy on cancer screening. But even if we throw that out the window and say we believe so much in this trial we're willing to set policy on the basis of it, if you look at the data, I'm not understanding where we get substantial net benefit. I wanted to ask this when our presenters could clarify it, but if you look at the 2011 paper, the 20% reduction in mortality from lung cancer in the 26,000 or so people that were screened amounted to 83 averted deaths. So you have that on one side of the scale, the 83 averted deaths. On the other side of the scale, in terms of potential harms, and this again is looking at the actual data from the study, unknown amount of anxiety, that data is pending, so the psychological harms we're not going to know about. 10,246 imaging studies, 322 percutaneous biopsies, 671 bronchoscopies, 713 surgical procedures, 228 patients with complications, 86 of those major complications, and 16 iatrogenic deaths. So whether that represents a close call or a leaning towards benefit is something we could discuss. There's not a common metric that was used to actually weigh whether there was net benefit or net harm, and that's often very difficult to do. But I don't see how you come away from that, even for the NLST sample, with substantial net benefit. Add to that the additional issues we're facing when thinking about an older population with different risk-benefit ratios and lots of other considerations we'll get into about the hazards of extrapolation. I really don't see where we get substantial net benefit there. But I'm interested in other panel members to reflect on, because I think that's question one that we're supposed to vote on, how they look at this evidence and see evidence of substantial net benefit.
Dr. Gould.
Yeah, so thank you for sharing that. So I want to address some of those points. I think you, for the most part, you've raised some interesting issues. One, I want to acknowledge certainly the people who are in the room who took part and helped execute the NLST. It was a triumph of clinical science. It was an unbelievably audacious undertaking, and it succeeded in hitting its primary endpoint, and I think you should be, publicly recognized for that. I think we're not going to have another NLST. We do have the smaller European studies that may help to shed some light on this, but I think the NLST is our last best hope for RCT evidence regarding the benefits and harms of CT screening. There are certainly some things we can learn about implementation of screening in practice settings that we can learn from uncontrolled studies and registries and whatnot. I think the balance of benefits and harms is really not clear, and I think this, I think we're accustomed to living in a world where we make recommendations for screening interventions that are either thumbs up or thumbs down, and one size fits all, and everyone should do it. And then we have the Postal Service create a stamp so that everyone knows to get their PSA. Well, not anymore, or their mammogram. Well, maybe not anymore. And for lung cancer screening, here we have kind of the poster child for a situation where every individual has to weigh benefits and harms. And how you make those trade-offs, 3 fewer deaths per 1,000 people who undergo screening, if you're at average risk, and risk is not average, none of us are average, and how you weigh that against the false positives, the follow-up scans, the psychological harms, the biopsy procedures. That's a very personal trade-off that people have to make with their physicians. I would say that it would be a mistake to not allow people to have that conversation and decide for themselves, but I can see how, others might disagree.
I mean, I think those are good points. I would say, I hope we've learned something, though, from our prior experience, because I think it's very hard for people, to understand the nuances of cancer screening, have the harms and benefits discussion. I mean, you look at PSA, and I would say it's certainly not a model. We now say a lot of men are being harmed. There's no net benefit, and, Medicare still covers PSA screening. Lots of doctors are doing it every day. Lots of people still, or look at mammography. What happened when the task force tried to pull back the 40 to 50-year-old group and say there were more harms than benefits. That's a hard message to get. I'm not saying we shouldn't get it, but I'm saying we should get it right, because it's very confusing to people. It's a very tricky message, and I think it's very important for us when we make these big recommendations, particularly for screening, to have good confidence in the evidence, because
Could I respond just
something.
to state in the record that
yes,
when
Wolf.
Steve Wolf, when you evaluate screening tests, there's 5 things you want to look for. First is burden of suffering. Second is the performance characteristics of the screening test. Third is the effectiveness of early detection. Fourth is the harms, and then finally the balance of benefits and harms. On the first point, no one in this room debates the burden of suffering. So clearly we have the leading cause of cancer deaths, a major public health problem. And on the second point, the effectiveness of early detection, I would even concede that the numbers needed to screen that were published in the NLST are superior to what we see for mammography and colorectal cancer screening. That's a very favorable ratio. The challenge I see is that the poor performance characteristics of this test, with the very low positive predictive value, and that the necessity that the screened population therefore undergo not only follow-up testing, but a certain subset undergoing potentially harmful and dangerous invasive procedures, shifts that benefit risk ratio in a way that we don't see for mammography screening or other types of screening tests, that in this particular case, in a highly controlled setting of the NLST, you could argue that the numbers that I just read out tip in the favorable direction, and that Dr. Gould is correct in saying, well, let's let that option be available to patients. But if those risk stratification criteria start slipping, and experience has taught us that they will, then one wonders whether the risk-benefit ratio starts tipping the other way, and we as a society are offering a screening test that causes more harm than good. And therefore, there becomes a public health duty to think about the appropriateness of that. If you argue that in addition to the NLST, there is the CISNET model that the task force based its recommendations on, I just want to read into the record the numbers from the CISNET model that the task force based its recommendations on. If you look at the table that the task force cited, and the particular row that is the basis for the 30 PAC years and 15-year quitting criteria, under that model, we out of 286,000 patients that would be screened in the hypothetical model, 521 lung cancer deaths would be averted. So again, put that on one side of the equation, and the morbidity benefits of reduced burden of suffering in terms of severity of illness that the patients would benefit from as well. So that all goes on one side. On the other side, for the 286,000 minus 521 people that don't end up having deaths averted, 19% of the population is exposed to screening. Approximately 25% will need a workup based on the NLST data. I understand that cutoffs might be different with other protocols. But under their model, this is the model the task force based its recommendations on, 1,359 patients would have major complications, and there would be 253 iatrogenic deaths plus 24 radiation-induced deaths for a total of 277 deaths caused by screening up against the 521 deaths averted by screening. So again, that's in the idealized risk group that the task force is specifying. Our ability as a healthcare system to ensure that all patients offered CT screening will fall into that narrow band, to believe that we will succeed in doing that is naive based on the years of experience we've had with the implementation of evidence-based interventions.
Thank you. Any other comments? Dr. Sidrakian?
I'm less concerned about one trial that is informing our decision making. I think what I'm more concerned about is really that we don't have very clear understanding of patient-centeredness here. I think we really have very large population in this trial, and we cannot come up with the groups of risk. And I've seen that in some of your presentations, highest quartile of risk. But I didn't see a specific characteristics, patient, radiologist characteristics that will help us to get more confidence about the population that is more likely to benefit from this than the other population. That's one concern I have. I wish we would have a bit more information about the highest risk group that is way more likely to benefit than others. It could help us certainly have more positive feeling about this test, particularly in light of other data that is going to come from Europe, and would help us certainly to wait and understand what the evidence, how evidence is evolving as more data is accumulating, and we'll have more confidence about the larger population rather than a specific population of highest risk. Second issue, I think, what I'm also less concerned about, whether this particular screening technology has more advantages than mammography or colorectal. Just to reflect on that, I think in the past 10 years, the way we judge the benefits and harms have changed. Remember 10 years ago, I would read Gerd Gigerenzer's publication about benefits and harms related to mammography. It was about arguing for this frequency-based approach. How many people get screened, how many people get benefit, and how many people are harmed. And it wasn't a mainstream thinking 10 years ago. While today, see how great the presentations were about specific benefits in terms of frequencies, and a discussion we're having today is also reflective of our better judgments and understanding of how to balance the benefits and harms for tests like this. So another point that I wanted to make about the small positive predictive value here. So we have seen data that says out of 21, 19 will be false positive, only one will have a cancer, but then there's a workup involved. And in the trial, about 6% of patients did get some inappropriate workup. I mean, I should call it inappropriate, but a workup that potentially were not related to cancer. Now, can this percentage be different in the real-world population? It appears that it's very possible because we don't really know what characteristics of the radiologists can help us keep this at this level or higher. So we heard a pushback from you about a academic setting or teaching hospital setting or any facility standards. So ideally, I would like to see also that kind of information to what would help us make a decision.
Okay. Dr. Grants and then Dr. White.
One of the difficulties I have along with Dr. Wolf's comments is that I've always had difficulties with these USPSTF reports is that, as are alluding to, is weighing frequencies because, and in this case, a lung cancer death averted is certainly nowhere as equal to any of the adverse, or not any, but most of the adverse consequences that are rather typically limited. That may not be the case in a frail older individual. So I find it very hard to put the benefits and harms on a similar metric. That's why I asked the question early on. I was looking for quality-adjusted life years, or even just life years by age and some uncertainty around them, which sort of subtracts the benefits and harms, the harms from those benefits. And because the trade-offs really are key here too for the Medicare population, where the NLST represents probably a small, not necessarily small, but the healthy subset and the trade-offs are going to be very different among the frail older folks. But I find this a very, very difficult to weigh because the mathematics in my head just don't come naturally.
Dr. White, I think you had a comment?
So going back
Dr.
to
Marcinia.
Where Dr. Bach started earlier this morning, and it's something that's been kind of a theme that's gone through this to me as I've tried to sort of look at the juxtaposition of the numbers and the data. So a part of this comes down to the link where Rita was in terms of net harms versus net benefits. And as an economist, I start thinking about rapid technology diffusion and what those numbers start to look like in terms of how Dr. Wolf and others have played in. And for me, it's becoming increasingly difficult to resolve the I, C, or B type of rating that one might want to make when you look at a coverage decision, because at some point it's, you know, this will go out to a broad population of individuals where the question of certification, as we heard from ACR, you know, it is lifting things up, but the fact of the matter is not every person who is ACR certified is necessarily doing a lung cancer test as well. And so there's variability in the system, to Rita's point, that seems very large as I start to think through this and look at the evidence that was sent to us in advance of coming here.
Okay. Are there any other comments from the panel? Because as Maria has kindly distributed the clickers, which means we are getting near time for a vote. Dr. White, did you want to make a comment?
Well, we've had some discussion about the rollout from academic centers to community centers. And I just have some comments about it. First, I'd like to say that the people have talked about the equipment differences between academic and community centers, and I think that that is not true. Every academic, in most large cities, academic centers have some fancy equipment, but they have a panoply, a spectrum of equipment that mimics, to a great extent, what you would find in other community hospitals in the same area. And a patient who comes in for a low-dose lung cancer screening may not get the Shazam Wampamatic machine that the university just bought. They're going to have one of the regular CT scanners, pretty much the same as they get down the street. So I think that that really is not something that we need to worry about. I'd also say that we talked about low-quality scanners and access. I think it's important, and this is an opinion, I don't have a publication on this, but 30 years of experience in a state that has both rural hospitals and city hospitals. Almost all the low-quality CT imaging devices are in urban areas, without a doubt. Small rural hospitals can't afford, generally, to have a junk CT scanner. But urban areas can have a hospital where they have 3 or 4 and one is the low quality, or referral patterns in a large city can be such that in a freestanding center, the center may not need to have high-quality equipment. So I think the rural big city distinction is also incorrect. It's not necessary to have the lowest dose of all contemporary equipment. I think it's only important to have a dose that is low enough so that the dose doesn't matter. And I think that and I think what I've heard today is that that's the case for easily achievable. And lastly, I'd like to say something about the importance of how if this were to be paid by Medicare, it is really important that all Medicare patients can be confident that they're going to have a quality low-dose CT experience comparable to what we've heard described in the one study with 50,000 people. We want that to roll out to everyone. What level of quality is acceptable? Only the best for Medicare patients. And the only way to do that, and I'm deeply respectful of voluntary programs, the only way to do that is through mandatory programs where CMS doesn't pay the bill unless you meet an accreditation standard. And we currently have that through MIPA with 3 accreditation organizations, and I think it's the thing that could turn the tide on this in terms of quality is for CMS to require in some way, and we don't get to vote on this, in some way that if one is going to get paid for a low-dose CT scan, one is accredited for a low-dose CT scan, and that needs to be not just on the MIPA side for freestanding centers, but on the HOP side for hospitals as well. Because currently, only freestanding centers are required to be accredited by Medicare for these. Hospitals get a pass. So I think quality can be had, but it's not going to happen on a voluntary basis.
And Dr. Burke, you will have the last but not least comment.
Golly. Well, I just have a few very brief points. Firstly, I think that somebody said that we shouldn't get it wrong now because it's going to be very hard to get it right later. And that's exactly right.
Dr. Burke, can you please speak in the mic?
Yes.
For our recorder.
That once a technology gets established in screening, it's very, very difficult to, if a new technology came along, it would be very, very difficult. Or if we found that this screening wasn't right, it'd be very, very difficult to change it. Look at PSA screening. Once it's in, it's hard to get it out.
This one requires an investment in capital.
Well, yeah, well, everybody wants to amortize their machines, and CMS expects a 95% amortization of their machines, so, okay. And I heard a lot about registries, but I didn't hear about who was going to create it, who's going to run it, and more importantly, who's going to pay for it. Nobody volunteered to say we're going to pay for the registry. I didn't hear who was going to control it, and I didn't hear who was going to require that everyone use it. And without all of those things being in place, I just don't see that as a very viable situation. Yeah, the study's an ideal world study, and I agree with my colleagues that weighing the risks and benefits is very difficult, especially when you have comprehensive cancer centers that really do a really, really great job, as we all know, of screening and follow-up, which is equally important in this whole thing, because it does no good to screen these people and then they don't come back, and treatment, and whether community hospitals can function at the level of a comprehensive cancer center, I think may not be an open question. I think that we haven't said much about life expectancy of smokers, but I think Dr. Bach had a slide that said that at 65, they had a 10-year life expectancy. At 80, they had a 4-year life expectancy. And this is just smokers. That's not high risk. That's just smokers. And I'm going to assume that, that the high-risk people that my colleague is looking for, are going to have a much lower life expectancy than this population, which I think complicates the whole issue of looking for high-risk people if they have a low life expectancy. This otherwise healthy patient thing gets thrown out here all the time. Well, if they're otherwise healthy patients, in this population, who's an otherwise healthy patient? I mean, how many COPDers are otherwise healthy patients? Not very many, okay? So I take umbrage at people throwing out, well, in otherwise healthy patients, this is what it's going to look like. And just a word about the radiation. We really don't know the effect of low-dose, repetitive radiation doses over 25 years. Most of the literature is done on single-dose effects, not repetitive doses over time, because it's very difficult. So I'm doing some animal models right now because it goes much quicker. But also, I just wonder if these people are genetically at high risk for lung cancer. In other words, is it in fact the case that many of these people are predisposed to lung cancer, and if you radiate them over and over again for 25 years, I'm not sure what's going to happen to them. And finally, we're kind of like an Alice in Wonderland world where if we wait 15 years, this won't be an issue because probably everybody will be screened at 50, and by the time they get to 65, they'll already been screened for 15 years. So it'll be a moot point. So all we have to do is wait 15 years, and it'll basically be a moot point what we decide. But coming on to the main point. Dr. Pinsky was very nice to give me the study, and I'm sorry that I nailed him on it, but you know, that's the nature of the beast here. Because, I mean, we're talking about, the question we have to answer is in the Medicare population, not an extrapolation from some other population, right? So we're not extrapolating from 50 to 65-year-olds and saying what's going to happen. What is the evidence in the Medicare population? And in fact, this study, the NLST, has evidence bearing on this issue. They looked at patients 65 or older and found no significant effect. So when somebody asks me, is there adequate evidence in the Medicare population, I have no evidence in the Medicare population that was presented today.
Just to correct what I said, by high risk I meant a group that would more likely to benefit rather than the highest risk, that more likely to die because of other causes.
Thank you.
Did you want to, Dr. Howard, did you want to address the last comment, which was
okay.
supposed to be
Well,
the
I
last
actually
comment?
have a question for someone else, so if it's not. But Dr. Wolf, you brought up some good points. A lot of the patients in the control arm of the trial had what were classified as intermediate adverse events. I was wondering, and I was looking in the trial, and they don't describe what that is until an appendix, and I don't have access to the appendix. So can you give us an idea, or do you know, what are we talking about here when we say an intermediate adverse event? Is it something that's going to harm
It did include a
quality of life for a
pneumothorax.
long time?
So pneumothorax was on that list. And Paul, you can correct me if I'm mistaken about that, but a pneumothorax requiring a chest tube, was that a severe adverse effect or an intermediate?
That's pretty severe. It's invasive. Yeah, it's an invasive procedure. Yeah, putting in a chest tube, the last time I did one, it was pretty invasive.
Hopefully that was a long time ago.
All right. Okay.
Yeah, my residents do it now. Thank you.
Well, I think we have now heard a good summary of the evidence, so what we know, what we would still like to know, what the remaining questions are, and we're now time for the vote. So I am going to read the voting questions. Dr. Gould, did you have an urgent question that?
Well, I did want to follow up on Dr. Burke's last comment, and actually I appreciate your comments in general. I think you make some excellent points, but at least I'm going to agree to disagree about the interpretation of the evidence vis-a-vis 65 and olders. I think they looked for a statistically significant interaction. They didn't find it, and you can disagree with the rules, but by the rules of evidence-based medicine, the effect was consistent.
That is why I'm calling the vote.
So, vote, Madam Chair.
But I just want to state,
No.
I know you want to move on, that I have additional concerns. I don't want to hold us up, but I just want to document for the record that I have additional concerns that were not discussed.
Okay. Well, we will have time, because after the panel all votes, I will ask each of you to state how you voted and give the reasons for the vote. So the voting, and just to remind you, the score that we use is 1, you have low or no confidence, and 5, you have high confidence. 3 would be intermediate, and you can vote 1, 2, 3, 4, or 5, only whole numbers. Okay, how confident are you that there is adequate evidence to determine if the benefits outweigh the harms of lung cancer screening with low-dose CT, defined as CT acquisition variables set to reduce exposure to an average effective dose of 1.5 millisieverts in the Medicare population? So again, how confident are you there is adequate evidence to determine the benefits outweigh the harms of low-dose lung cancer screening in the Medicare population? You can click now. I think we're done. Okay. So the vote on that was a mean of 2.22, so that is a low to intermediate. I will just note that that means we're not going to go on to A, B, and C, so we can now go on, and I don't vote.
Sure, I voted 3. And the reason I voted 3, despite my uncertainty related to the overall population, I do believe there is a very large subgroup of patients enrolled in a trial and eligible for this screening that would substantially benefit from this technology. We just need to report it and find that subgroup. Maybe it's future research, but I think it's really something that should have been part of our discussions today based on evidence.
And I just reminded Dr. Sidrakian, state your name before you
Art
start
Sidrakian.
talking.
Fendrick, 2, no comments.
You have to tell them how you voted.
I said 2.
Oh, okay.
And you
We're not going to get out of here.
Well, I'll talk.
I know you can talk.
Okay, I'll talk. Anyway, Harry Burke, I voted 1, and I think I stated my reasons. I didn't see any significant benefit in the Medicare population.
It's Mark Grant. I voted a 3. I think that it's a difficult question, obviously, because the Medicare population is a fairly heterogeneous one, but representativeness vis-a-vis the NLST is really a critical issue, and I'm not entirely convinced of that as extrapolating to that population. Nevertheless, I do believe, or my assessment of the evidence, the NLST, in terms of the relative benefit and harm, that there is a substantial portion of the Medicare population that could accrue benefit, albeit recognizing there are significant trade-offs here, and those decisions really should be made on an individual basis.
Joe Carroll Hyatt, I voted 2, and actually similar thoughts as Mark's, but I got stuck on adequate, and I just didn't feel that there is really adequate evidence at this time, and it's promising, but we certainly need more information before making a broad statement about benefit to the Medicare population.
This is David Howard. I voted a 3. While I recognize some of the limitations associated with the trial and screening in general voiced by the other panelists, I'm a bit concerned. The mantra of the evidence-based medicine movement has always been we need to test new technologies in high-quality, multi-center, large randomized trials. And in this case, we have a large multi-center trial that showed evidence of mortality reduction. So I just worry that we might be setting a threshold so high that new technologies, that no new technology could pass it. I don't think we need to become the Amish of medical technology and freeze things as they were in 2014. So, just in recognition of the fact that this high-quality trial exists.
Gail Melkus. I voted a 1, and maybe I was very literal in reading adequate evidence and harms versus benefits in this population, the Medicare population, which was a small group.
This is Curtis Mock. I voted a 1. And the reason is that I think it's almost impossible to extrapolate to the Medicare population the expected results that we would get, when I feel it's our obligation to first do no harm. I didn't find it. I thought I would today, and I didn't hear that the evidence is there to support benefit beyond harm.
Gerald White. Well, I voted the 4. I thought 3, struggled with 3. I thought that 3 was too wishy-washy. I felt I needed to make a stand one way or another. I think that this was a trial that is not going to be repeated, and there was unlikely to be a better trial. So focusing on the word adequate, I thought that we should accept the results of this trial as had been previously described, because I don't think there is ever going to be something that is more adequate.
So Martin Marciniak, I voted a 3 for reasons that Dr. Sarkeesian and Dr. Howard had already stated.
And I voted a 3 as well, and I think
State your name.
Sorry, Paul Doria Rose. I voted a 3 as well, and I think my main, I would echo the same comments about I believe strongly that there is a subgroup who would benefit. It's a matter of finding those people.
Michael Gould, as a non-voting member, I voted 3, and my main rationale for that is that the issue of generalizability, specifically regarding harms to settings outside of the NLST and in the Medicare population, I think the rule of thumb should be to generalize beyond the trial unless there's a good reason not to, and I think the Medicare population and the settings outside of the trial are substantially different than what we saw in the trial, and I'd like to see more evidence from future observational studies before I can be certain.
Jeff Rich, I also voted a 3 for many of the same reasons here, but for an additional reason. I think we saw a lot on the benefit side, and the harm side seemed to bother everybody. But I want to remind everybody this is a clinical trial, and clinical trials act differently with patient outcomes than with
real-life data. And I think Dr. Wood made the comment that we're just learning how to handle these nodules. Do they need to be biopsied? Do they need to be removed? So I think there's a learning curve here, and I think that the harmful side that we've seen is probably going to go away or be very diminished over time. And I would not like to suppress technology, as somebody said. I'm pro-technology, and I think we should extend this to the Medicare population.
Steve Wolf, I voted 1. My reasons are similar to my colleagues and comments I made earlier about questions about whether the magnitude of benefit observed in the NLST is generalizable to the other populations, and concerns about whether the harms could potentially offset some of those benefits, especially if screening extends beyond the narrow risk group that the recommendation applies to. The point I want to reinforce that my colleagues made is that it's not realistic to expect lots of NLSTs to get conducted. We're probably not going to get a better randomized trial than the one we have, but the solution to that is modeling. But those of you who've studied modeling understand that when you see one model, you've seen one model. And that the CISNET model is very interesting, very sophisticated, very informative. But we can cite many examples of other cancer screening tests where modeling studies over the years have reached different conclusions based on different assumptions that go into the model, different kinds of models, simulation models, agent-based models, and so forth. And I think the literature, the more that modeling is done on this type of screening, we'll continue to see a more diverse set of outcomes and results than what we've seen now. I take advice from the chair. I have a series of concerns about challenges that we might face if CMS were to cover this in trying to replicate the conditions in the recommendations. Should I list those, or in the interest of time, do you want to just move on?
If you want to list those, feel free, and it can be for the record.
Okay, for the record, and I apologize to everybody for listening to this, but the recommendations from the task force that are the basis for this NCD specify that screening be offered within certain parameters. And if you look closely at those parameters, I see implementation challenges in keeping to that risk group, both in terms of the feasibility that practices will face in actually following through on this, and we have plenty of experience in healthcare to know that these challenges are real. And the tendency is for those criteria to slip, and that means a lower risk group will end up getting screened, and the risk-benefit relationships that we are basing this recommendation on will no longer apply. First of all, the age group. It's supposed to be age 55 to age 80. But we already know from discussions today that there is a sentiment to move that to an earlier age group, to start screening earlier. And also we've heard comments made about the inappropriateness of cutting off screening at the proposed stopping age. So it's quite likely that it would not be limited to that age group. The 30-pack year and the 15-year quit rule, operationally, pragmatically, the implementation of that will be challenging because of difficulties with screening and intake. We have heard testimony from centers of excellence that have developed systems for doing this, and I applaud them for it. But the feasibility of expecting that to be done nationwide with implementation of this coverage policy are quite challenging. Plus, there is a strong sentiment from many of the organizations that testify today and others to loosen those criteria and accept a 20-pack year history and so forth. And Dr. Bach noted that when you do that, the number needed to screen now shoots up to 3,000, and the whole risk-benefit ratio potentially starts changing. A detail, a nuance in the task force recommendation that no one has discussed today is the provision that this only be done for people who are able and willing to have curative surgery. Those are two different things, but we haven't discussed either of them. How will we define who is able to have curative surgery? We've had some surgeons indicate today that there's hardly any patient who would not be eligible for curative surgery. And even those who are considered clinically appropriate for the surgery, willingness to have surgery, once informed of the potential consequences, how will that actually be implemented? Challenges to image interpretation, I won't belabor that because I think we've had a lot of discussion about how we will implement a policy of ensuring that all radiographic facilities that are doing low-dose CT screening will adhere to the criteria of the NLST. And there are wonderful efforts we've heard about today from the professional societies trying to make that happen. Most sound like they are going to be voluntary, and I agree with my colleagues that the only way to actually make set limits on a runaway problem like we've had with other forms of cancer screening is to tie reimbursement to that, so that coverage would not be possible unless there was documentation that those criteria were being met. The concern has been raised that if we limit screening only to facilities that are state-of-the-art, such as those at academic centers or even community-based facilities that are state-of-the-art, we are contributing to health inequalities because so much of the population, especially geographic areas at high risk of lung cancer, don't have access to those facilities. That argument only holds if one accepts the premise that screening results in more benefit than harm. Screening done poorly, if one is open to the premise that screening done poorly results in more harm than good, then one is actually committing an ethical error by exposing disadvantaged populations or people who are disadvantaged geographically to a form of imaging or follow-up workups that are actually going to cause more deaths or cause more adverse outcomes than benefit. And that is equally troubling ethically as barriers to access. Another concern is whether clinicians will actually wait for the annual interval. We have time and time again with other forms of cancer screening, pap smears and many others we can mention, where recommended intervals for screening have been have had a slippery slope, and there's been a creep in the interval of frequency of screening that I think will be hard to adhere to. Another topic we haven't discussed today is the 95% adherence rate in the NLST. Our ability to ensure that the millions of Americans who would be offered this form of screening will achieve 95% adherence, a rate that I have not seen achieved for other forms of cancer screening, is very doubtful, especially when one considers that 95% was achieved in a population that had higher socioeconomic status, higher educational attainment, and a younger age than the population that would actually be receiving this screening. There's reason to believe that lower SES patients and older patients might face more barriers in actually following through on the recommended protocol. Will treatment in the community follow the same protocol? We've seen evidence presented of wide variation even within the NLST centers, the centers of excellence. It's only reasonable to assume that there would continue to be variation in widespread population use, and even worse, potentially. And then the point made about the surgical complication rate, the very good results that were observed in the NLST, and if I understood correctly from the NLST paper and Dr. Bach's testimony and so forth, the complication rate was 1/4 of what's typically reported. So again, when we're talking about a very tenuous risk-benefit ratio, I think these substantial differences in outcomes could tip the scales in the wrong direction. Thank you.
Thank you, Dr. Wolf. And that was very long and thorough. I'll just actually add, though, it was because it reminded me of two specific examples, and it's not really a lung cancer specific, but really, and not even coverage specific, but more Medicare specific. But when there is, for example, cancer screening and colonoscopy, we know that there was a study by James Goodwin looking at the Medicare population where colonoscopy is supposed to occur every 10 years unless there was evidence of a problem, but Medicare routinely pays for colonoscopy at intervals much closer to 3 to 5 to 7 years. And so it is, I think, hard in actual fact for Medicare to seem to follow its own guidelines on cancer screening intervals. And similarly, for a different national coverage decision with the ICDs and the cardioverted defibrillators, there was a study published in JAMA looking at the data registry that was mandated by CMS with that coverage decision that found more than 1 in 5 ICDs were put in contradiction to the actual Medicare guidelines, and the guidelines were set up because they were supposed to define the populations where benefits would exceed harm. So I do think it's unfortunately, a bigger, as I said, issue than for this committee to deal with, but the issue that it does seem hard for the criteria that clearly defines benefits and harms to actually occur in practice for Medicare beneficiaries. So with that, we will move on to the second question, and I'll just read that again. And I was trying to get some music for our, which I'll work on for the clickers. How confident are you that the harms of lung cancer screening with low-dose CT, average effective dose of 1.5 millisieverts, if implemented in the Medicare population, will be minimized? And then there are some questions for discussion, but we'll get to the discussion after the vote. So we're voting now again on the question of how confident are you that the harms of lung cancer screening with low-dose CT in the Medicare population will be minimized? And again, it's a 1-5 vote. Yeah.
Slightly there. Huh?
Okay. So the vote on that was 2.33. So again, a low to intermediate confidence vote. And we do have time for discussion. And I will just point out to you the discussion questions to consider when you just talk about your vote, which are: what harms are likely to be relevant in the Medicare population, including A, harms from the low-dose CT itself, harms from the follow-up diagnostic evaluation of findings in the lungs and incidental findings outside of the lungs, and C, harms from treatment arising from positive and false positive results. What provider and facility criteria or protocols are helpful in minimizing harms? Dr. Sidrakian.
Art Sidrakian. I voted 2. My thoughts about the minimizing harms were influenced that the mistake that Dr. Redberg talked about, the 1.5 versus 15, and the opportunities to do mistakes, and whether we have any decision aids, any softwares implemented that will be foolproof in a very busy cath labs, in a very busy radiology departments with so many of these scans done every day. Machines never stop, and you have to recalibrate suddenly and do a low-dose CT. Maybe I'm wrong here, but I feel like there is something here that I don't understand well, and maybe someone else on the panel can explain to me where is my mistake here. But to me, it feels like the implementation from that perspective might be an issue, and the harms potentially by creating this kind of a decision based on the level of radiation can in fact backfire, then would end up having many people with much higher radiation that we thought we would be having. So I also didn't feel like we had a proper evidence presented to us about harms that can be minimized from the workup. And the size of the nodule was one that has been discussed. Was it satisfactory? Was it good enough to reduce the potential for inappropriate procedures after the CT scan? So I wasn't confident that we heard enough and how robust this would have been in terms of criteria that would help us to make a better decisions. Those are the 2 points that I wanted to make.
Mark Fendrick, I voted 2. Senator Morris Udall said, everything is said, but not everyone has said it. So I'll say some things again in a different way. I always have problems with the language of these questions, although they're better than most, about what we mean by the Medicare population. And all my votes are divided by if the patients who you think should get this intervention, as opposed to the patients I know who will get this intervention based on experiences that Dr. Wolf had mentioned. So I voted 3 because I think you've done everything you can, and superbly done, in the very narrow targeted population. But since no one was willing to voice any response to my concern that there will be tremendous off-label use, some appropriate, some inappropriate, the harms will not be, Dr. Redberg, A, B, or C. But the harm I worry about will be the intervention of this test on people for which we know nothing about the benefits and harms.
Harry Burke, and I gave it a 2. I agree with my colleague. Indiscriminate use could be a major harm. I think the low positive predictive value drives harm. Whether, as my colleagues pointed out, you can balance that harm with the benefit is a very difficult business. But the low predictive value is a major problem for me.
It's Mark Grant. I voted a 2, but probably looking at it again, I probably might have voted a 1 because it's really asking me to predict the future, which is based on past that has a questionable, well, not complete relevance to what the future might be. But in addition to what people have expressed throughout the discussion, the one harm that troubles me as a potentially the most is that the use will extend to older, frail individuals who, in fact, the harms will vastly outweigh any potential benefit. And as, for example, I mean, if NCCN guidelines are adopted and those 2B recommendations look to me like there's going to be a fairly substantial creep in terms of patients that will, in fact, undergo screening. And that concerns me from my geriatrician hat, because I think the detrimental effects of overdiagnosis and some of the procedural things, a chest tube in a 65-year-old that can get up and walk many blocks is one thing, but for an 80-year-old who has a difficult time getting out of a chair, it could spell substantial, or if not just catastrophic, morbidity.
So Joe Carroll Hyatt, and although I'm a surgeon, I spend a lot of time with my radiology colleagues, and I want to correct Dr. Sadrakian's concern. The equipment is quite sophisticated. As long as the correct procedure is entered into the machine, the right protocol will follow. It's very sophisticated in that way, but that was part of the reason I was curious about, could we really be sure that people weren't getting diagnostic chest imaging studies rather than the low-dose protocol? And that is, I think, still in some systems, I think that remains a risk. I should also point out that the instructions to the jury, so to speak, before the session this morning were that we were to assume that there would be no real conditions on these questions, that there wouldn't be registries, there wouldn't be coverage with evidence and that sort of thing, that this is the basic thing. So I read this question as not necessarily having all the quality and certification controls imposed by the ACR and other institutions, that we wouldn't necessarily limit to certified sites, that this was basically a wide open opportunity for my vote, so I voted 2.
This is David Howard. So I'll recognize, I voted a 3 while recognizing the issues with the expansion of the technology outside the target population, and I'd be particularly concerned about expansion to people who have fewer than 30 pack years of smoking history. I also recognize that I think, as Dr. Rich said, that I do believe learning curves are real, and that as we gain experience, the benefit to harm ratio will probably become more favorable over time. And so I think that is important to take into account.
Gail Malkus, I voted a 3 for the same reasons that you just mentioned, Dr. Howard.
It's Curtis Mock. I voted 2. And the reasons are that I really think that there's positive intent. This question doesn't ask about evidence. This question asks about, do I think? I do. I do think that people have positive intent. I do think there's intent to do the right thing. But I don't think we're aligned. And until we're aligned, until we have those processes in place that Dr. Hyatt mentioned, I think it's hard for me to go higher than a 2. Certainly as time goes on, when our incentives are aligned and when our outcomes are the focus, I think that we'll have that process built. We'll have those protocols stabilized. And I think at that point, we'll know the results and be able to launch confidently that the Medicare population would be at lower risk.
Gerald White. I voted a 3. I thought with implementation I should take my number down one level. Implementation always introduces problems and uncertainties, I think. And I have to confess that I think there's a lot of potential for a really high-quality Medicare implementation along some of the lines that I've described, but I'm not 100% sure they have either the legislative authority or the regulatory regulatory power to or desire to do that. I do think, on the other hand, there is the potential for reduction of harm in standardization of post-positive finding clinical handling of the patient, which was not a part of the study, and I think that that has potential to significantly change the negative outcomes after from false positives.
So Martin Marciniak, the comment that I made earlier is sort of what's on my mind, so I voted a 3. I worry about rapid technology diffusion. I have a concern about that because we don't necessarily know how the net benefits versus harms are sorting themselves out yet. I voted 3 because I believe that we'll get there and there will be a net positive benefit, and that's how I ended up with that vote.
And this is Paul Doria Rose. So I voted a 2, you know, I applaud the efforts of the presenters today who have been working very earnestly to decrease, come up with protocols that decrease dose and refine our definitions of positive. And I think there's, you know, that to me is where the minimizing of harms, the ability is there, but the lower confidence is reflective of my concerns about what's going to happen in routine clinical practice.
Michael Gould, I voted 2. Essentially concerns about generalizability and implementation. I think this is an opportunity, should a coverage decision be made, to cover with evidence, and really the only possible way we're going to learn about harms in usual clinical practice is to make that kind of decision and have that kind of policy.
This is Jeff Rich. I initially voted 3, then I changed it to 2. I think I agree with you. There's going to be serious implementation problems here, and I'm worried that when you took, in this question, you took away the benefit part of it, and you left me with just the harm part. I want to be certain that we implement this thing right, so I think there's potential harm in poor implementation.
Steve Wolf, I voted a 2, and like my colleagues, I voted a 2 rather than a 1 because I think there are some really, there's a lot of hard work going on in the professional societies and among my clinician colleagues to try to reduce the adverse effects. And I think already the rates are relatively low. The problem that I see is that the absolute benefits are also relatively low, although you know there's that 20% reduction in mortality. If you look at the absolute benefit in the NLST, it was 2.06% deaths in the control group and 1.75% in the intervention group. So the difference, I think, is 0.31%, if I do my math right, of the population that benefited. So when you're dealing with numbers that small, then complication rates that are also relatively small could actually compete with potential benefits, and very slight tweaks like quadrupling the complication rate from the surgical procedure could really alter things. So I applaud the efforts, but I think I would also have given this, based on the advice to the jury ahead of time, I would have given it a higher vote if, for example, we knew that facilities could not be reimbursed unless they were actually collecting and documenting data to confirm that they were achieving certain thresholds of safety. The other thing that we haven't discussed today is Dr. Bach's recommendation for shared decision making. So a policy that would not allow for coverage without at least sitting down with the patients and letting them know what these numbers look like, using these tools, these decision aids that are available, I think would ethically make things feel more appropriate if we are going to go forward with this policy.
Thank you all for your thoughtful comments. And that brings us to our last voting question, which I will read. How confident are you that clinically significant evidence gaps remain regarding the use of low-dose CT, average effective dose of 1.5 millisieverts, for lung cancer screening in the Medicare population outside a clinical trial? And I'll just remind you, this is a little different. So if you're very confident there are evidence gaps, you want to go high. So, if you think there's no evidence gaps, then you would be voting low. And you can vote. One more.
Harry. Hey, Harry.
I want the music.
Maybe when someone's abstaining.
Why don't you press your button again and maybe we'll get 9.
Harry's abstaining.
There we go.
All right. Okay. So there was a 4.444, so that's a high confidence that there are clinically significant evidence gaps regarding the use of low-dose CT. And so we now have 6 more discussion questions. And so when we go down the panel to talk about your vote and why you voted that way, please discuss whether these or other topics should be considered for further research. In the interest of time, I'm not going to read them all, but you have them there, and you can discuss your vote, and in particular, whether you think there are evidence gaps in what's listed, risk factors, et cetera.
Art Sadraki and I voted 5. All of these are certainly important gaps, and we talked about them throughout the day. I think I would like to see maybe a discussion about which gap is going to be most critical for raising our confidence in this technology. And I think the most important gap that I see, again, that we talked about before, is based on totality of the data, both from this large trial, which is excellent trial and high quality, but also the publications from other trials, be able to come up with a cohort, a subgroup, in any way you would like to call it, where we would have much higher confidence that there's benefits outweigh the harms than in other subgroups.
Mark Fendrick. I voted a 5 as well. I'm looking over the 6 questions. So my gaps are not about radiation dose or not about venue. I think all of those things have been very well addressed. Mine is number 7. Of course, to repeat again, is whether we would be able to figure out that the right people get the right interventions at the right time. And my last point I think I'll make is that one of the great positive experiences I've had sitting on this organization for quite some time is lung volume reduction surgery. Mm-hmm. And I think it's somewhat coincidental that we have the same dedicated academic and community-based surgeons who took somewhat of a mixed up or uncertain diffusion of a technology, and through coverage with evidence development has led to a really superb and probably one of the best examples how we've gotten a surgery that was somewhat getting out of control to now, on the base of evidence, getting only performed on the people who benefited the most. So, Tamara and Rita, thank you for having me. Art, thank you for your service. It's great having you.
Yeah, hard to follow up on that. Thanks, guys. Okay. So I voted a 5. Yeah, all 6 of these. I just think that the whole thing is underdetermined. I think that, it just has to come together a lot more than it did today. The evidence, there needs to be more evidence, there needs to be better evidence, it needs to be more coherent, it needs to be integrated better. But I see a future for it if that's done.
It's Mark Grant. I voted a 5 as well, and would also say that though the whole list is important, just a couple things. The first, I really would like to see the quality of life data and particularly as it pertains to the elderly population, a little bit more even functional status, and I think the psychosocial issues bear some attention. And the last, which is something that's not listed here, which I've alluded to in discussion briefly along the ways, is I really think a gap is our metric in which we discuss net benefits and harms. And I think it'd be very helpful if something were adopted and used that could be communicated in a transparent way that placed them all on a similar scale, albeit with all the limitations thereof. But I think it would make the conversations a little bit easier. I think it would allow quantifying uncertainty and what the value of future research might be in particular areas to reduce that uncertainty. Yet throwing the balls around, it's always challenging without at least some common scale, at least for me. And I think that if we use it, we might get used to it.
And this is Jo Carroll Hyatt. I think I was struck by Dr. Bach's comment that 4 out of the 5 models are wrong. They were all different. And since the screening in the Medicare population is very largely based, especially the extended age, on modeling, I think we need to validate the model with some additional data. I also think that there's an enormous opportunity to mine the data from all the scans that are done and produce perhaps something analogous to computer-assisted detection in mammography, where maybe we can get much more refined in determining additional features of these nodules beyond just ground glass and size, and perhaps look at the borders, look at the real density, additional data that we, with thousands and thousands of these images, that we could perhaps learn something, looking at them in parallel with all of us with electronic medical records and understanding what the various biopsies and things show, and how the patients are doing. We should get a lot better at doing this screening. So I did end up voting a 5, and I think it'll be exciting.
This is David Howard. I voted a 4 for the reasons that Dr. Grant has already stated.
I'm sorry. I apologize. Dr. Melkus had to leave early. I have her vote, and she voted a 5.
This is Curtis Mock, and I'm doubly negatively challenged. My form that I signed says 4, but my button that I pushed said 2. So I'm very confident that we've not yet closed all the gaps in decreasing the risk for the Medicare population screening outside of a trial. I think it's been said repeatedly today that the structure is not in place from the certification of the screening, whether it's academic, whether it's community. I still was a little bit surprised today that St. Joe's today in Phoenix is a community hospital, but so was the hospital where I practiced that had 26 beds in an ICU. They're both community hospitals, and I think the definition across the country is quite variable in that regard. So, yes, I still have concerns that there are gaps around standardization and protocols, and my vote is 4.
Jerry White, I voted 4 also. It's tough not to vote 5 when somebody asks you a question, are there things that you don't know? Generally, my answer is an enthusiastic yes. But I do, if I had to pick something I think of most important, it's Roman numeral 4. I think the key to making this a better process is the reduction in harm of for the false positives, people who have a positive report but don't actually have lung cancer. That's where the improvements are going to lie in this process. And I just wanted, for the record, make a comment about somebody previously mentioned that we didn't know the harm from repetitive low-dose CT scans of this type. And I think the answer to that question is we do know. At 1 or 1.5 millisieverts per year for 25 years, I think there is adequate data to indicate that it's not, that has no medical significance. There are studies of large-scale population in high and low background areas where people have exposures like that for their whole lives, and there are no significant findings there.
So Martin Marciniak, I voted a 4. As previously stated, I think the most important of the points there is number 4. It's sort of the net harm versus net benefits.
Paul Doria Rose, I voted a 5. And for me, the key words here were outside of a clinical trial. And you know, my feeling about the biggest thing we're dealing with is in a population with likely a much higher burden of comorbidities than the population that was included in the NLST trial. I'm worried about that this balance of risk and benefits can be affected considerably.
Michael Gould, I voted 4. Could have been a 5. Looking at the list here for discussion, I think there's reason to be concerned about the evaluation of incidental findings, whether that's going to cause more harm than good. And I think the smoking cessation data is still completely unresolved. There's been some anecdotal reports of favorable behavior change, but none of it is, if you look at the 2 controlled trials that I'm aware of, they're on either side of unity in terms of the results. For the record, my greatest concern and where I think the most important gaps in evidence are in the area of evaluating screening detected lung nodules, and that is based on my experience writing about and caring for patients with incidentally detected lung nodules, and this has been a problem for 30, 40 years. In addition, people have mentioned the NCCN guidelines for nodule evaluation. The ACCP also has guidelines for nodule evaluation. The first edition of the ACCP guidelines was published in 2003. The second and third editions were published in 2007 and 2013. I chaired the nodule evaluation group for ACCP. We made 29 recommendations in the most recent third edition of the guidelines. 27 of those recommendations were weak recommendations based on low quality evidence. So they were 2C graded recommendations. There are no randomized trials of nodule evaluation. There are no good observational controlled studies. It's a completely uncharted area. We need better evidence there.
Jeff Rich, I voted a 4. There are gaps, of course there are gaps, but there are gaps in any new technology. I just look at transcatheter aortic valve replacement. When that rolled out, there were so many gaps, but we went ahead and we wanted to get that technology out. And in fact, the results post-commercialization are better than they were in the clinical trial because we got smarter with time. So here I would think that, I just want to go on the record saying I think this is an important clinical tool for our patients. I really think if we don't want to implement it in the entire Medicare population, I think it does need to be studied somehow, some way in a pilot or in a registry setting in certain centers, because otherwise we'll never have an answer, because there is not going to be another randomized clinical trial for this.
Steve Wolf, I voted a 5. Most of my reasons are the same as my colleagues. In terms of unanswered questions, in addition to the ones listed here and the other good ones that have been suggested, I'd like to add one more, which is prudent use of resources. We need to think about, if we do cover this, basically, if you think of this as CMS writing a check for a strategy to reduce deaths from lung cancer that we know are largely caused by tobacco, and year after year the CDC reports significant shortfalls in funding to states for tobacco control efforts, whether it wouldn't make sense to allocate our resources directly at tobacco control interventions, where we would see absolute risk reductions that would eclipse what we're seeing with early detection of lung cancer through CT imaging. That's not to suggest that the important findings reported by the speakers today about how CT screening might encourage people to quit smoking shouldn't be recognized and applauded. But I wonder whether our dollars could go further in actually saving lives from lung cancer by dealing directly with tobacco abuse.
I just wanted to address one of the earlier comments that was made, because there is data directly estimating the number of fatal cancers per millisievert, which is 0.05 fatal cancers per sievert of exposure, which means that for the NLST, there would be expected 1 cancer death to result per 2,500 patients who underwent 3 annual low-dose CT scans. So there is a number, and it is more than 0. And obviously, it goes on to say if those people got diagnostic chest CTs, there'd be 1 cancer death per 550 who went 3 annual screenings. But I really want to thank everyone who came today. I want to particularly thank Tamara Surik-Jensen for leading our group, Maria Ellis, my vice chair, Art Sadrakian. I want to thank all of the presenters, the people that attended today, the public comments, and especially the committee, because I think that clearly, we are in a very interesting time of trying to look at the evidence, balance harms and benefits. I think we're having really important discussions that need to be discussed, but that are really not that easy for anyone. I think we used to think a new technology, that's good, and we're really talking a lot about, well, what does this new technology mean? What does it mean in this particular population? What are the risks? What are the benefits? How could it best be used? And those are really thoughtful questions, and I know everybody here has all the best intentions to do the best things for all of our patients, our Medicare beneficiaries, for us in particular. We all think very highly, of course, of the NLST. That was a very well-done trial, and I want to thank the committee for all of your work.
Just a very quick comment for some of you that are doing research in new technology. One of the new ones is the e-cigarettes. That's another gap. We have no idea what to do with those.
It is certainly a concern. So that's a good idea for another.
Yeah. So I just want to say thank you again to the panel, and I especially want to say thank you to Art, since this is his last MEDCAC, and then he takes a year off. So thank you for your tenure here. You've done a wonderful job. Thank you for everybody, and thank you for the speakers. I think I'll be hearing from many of you. We have a big job ahead of us. And remember, there is another public comment period coming up as soon as we issue our proposed in mid-November. So look for that. Thank you very much.
Thank you, Art. Thank you.